Again, thanks very much for inviting me to the conference. It's truly an honour, and we had great fun this morning with Carl, and I look forward to this session too, and sharing with you, I guess, a journey that there's so many people, and we've heard from Andy Carr and the great work of Michael Carr and so many other researchers and people working in this field. And this presentation, in a way, is to try and recognise both across the breadth, the depth, and diversity of inputs into our understanding of perhaps where we are at the moment in tendinopathy, but also in an attempt, perhaps, and I think rather crudely, to look forward as to where we might be heading. And look, it's been quite a journey, but actually not a very long journey when we look at it compared to some other challenges. And also we can reflect on the number of journals or the journal articles. About 8,500 now, and about 500 a year, which gets desperately difficult to keep up with. But again, some really good work, and it seems to have plateaued a little bit at the moment. But really, very much a poor cousin when we compare ourselves with osteoarthritis and some of the other, I guess, more mature interest areas. But then I did this, again, rather crudely a couple of years ago. I've looked at, of all the publications, which of these are really adding to our science of understanding of tendinopathy, and it was really only about 20% or so that the rest were taken up with interventions and a number of other aspects, which and where this paper or this presentation is really very much more about understanding the entity of tendinopathy as such. I won't talk about interventions. There are others far better than I to do that, but to really concentrate more on our understanding of now this diverse and multi-dimensional issue. And I make the comment here that very few of our contributions to date have really looked at tendinopathy prevention, which is highlighted, or this question is asked in this particular slide. So in 1976, Bill Clancy wrote an article, one of the first case series on Achilles tendinopathy. There were 5 patients. And in reply to that, in I think it was American Journal of Sports Medicine, Bob Curlin, a very esteemed clinician at the time, wrote a couple of quite interesting comments. And the first was really pulling together a thing that we still continue with today, that it's really the sort of response to microtrauma after the stress of athletic performance. And if I can add too, that I'm going to talk perhaps more from my biased perspective, if you like, of lower limb tendinopathy and more about athletic tendinopathy. More just to put some context around that, and I wouldn't pretend to go where people like Andy and Chris Littlewood and others do in the upper limb, and I'm happy to stay where I am, I think. Robert Curlin's second point was that there's a number of different terms and classifications used, but he felt that all of these were really relating back to the same singular process somewhere along the line, and perhaps we're starting to see and appreciate that more as an entity in the present day. His challenge that he threw was to why the same degree of stress in one athlete produces a tendinopathy, whereas others survive uninjured, and that's been an ongoing challenge, and perhaps some of the things out of today might tease that out. And lastly, some more or push for some more interest in prevention. So it has been a long and winding road, and really tendinopathy was first described in the 20s and 30s, and this was more in the upper limbs and very much occupational overuse. And so primarily it was the design of factories and this ongoing repetitive nature that was producing both shoulder issues, but also there's quite a lot written on wrist de Quervain syndrome and that sort of thing. A little later we saw of Achilles paratendinitis through Hölmich and others, and I did look for being aware that a lot of the early Scandinavian material hasn't been published in English, so I was unable, and I apologise for not finding any of your more native contributions to the area. In the 70s, we started to see some publications around this lower limb tendinitis, and it really correlated with the onset of the running revolution. So those of you who remember Jim Fix and others, so people going out and running much more than they had previously. In these early days, though, there's some quite good understanding of or contributions in terms of the systemic associations with tendons. So things like our rheumatic diseases and ankylosing spondylitis and others were identified actually fairly early. A number of very good vascular studies looking at the microvasculature of the tendons, and also as early as the 70s, so over 40 years ago, the deleterious effects of cortisone, and that was mentioned as recently as yesterday. So the 70s and 80s, as I said, gave us a whole plethora of certainly lower limb injuries, generally related to this jogging or increasing jogging. And it started off from pretty small case series and ended up with quite a large series in the hundreds with Rolls and Martins, and also Williams, whose was primarily surgical. The original paper challenging this point that it was at that stage considered inflammatory was that of Purdam, and it's actually a really nice article. If you can go back and look at it in a historical sense, it has some really very good insights, I consider. In the early 80s, we had the magnificent publications, a very large series, 891, I think, Achilles or tendon ruptures by Canis and Yoza and others. And they were able to tell us then that really tendon rupture can occur in the absence of tendon pain. So it actually teased out the fact that pathology and pain are not necessarily linked, and that's something that lives to the present day. A couple of early forays, I guess, into the areas of loading and biomechanical factors, and this was really the Canadians of Taunton and Clement. But also playing volleyball on hard surfaces. For patellar tendinopathy was identified by Ferretti, finding that concrete courts were nowhere near as good as wood courts for your knees. If we looked at 90s, I've already mentioned the Canis and Yoza paper, but also Williams had a very, very large series of Achilles tendons that went to operation. And to give you some context here, that if the tendon hadn't recovered within 8 weeks, that they then went to operation. So he was actually, almost by dint of this, be able to capture some pretty early changes within the Achilles tendon, which were described fairly vaguely at the time as minor or mild changes within the ground substance of the tendon, end of story. And although that probably gave us a little insight that it was more than just this purely degenerative process in the early stages. The 90s, where we saw the commencement of some of the nicer thinking and some animal models that provide basis, certainly for Ledbetter's article in 1992, and this was, I think, really set up very good understanding, perhaps a better insight of what's happening in the tendon cells, as well as looking at the collagenous matrix as well. And a very large surgical series looking at both partial or partial tears within the Achilles tendon in particular, and identifying there that the tears really only occur in areas of degeneration. So again, probably reinforcing some of the earlier work of Canis and Yoza. And here's Ledbetter's model, but I'll go through this in only brief detail a little later. If we look at the 90s, we saw then the introduction of ultrasound, and it's fantastic to see some of the high-resolution ultrasounds today, but these ultrasounds were nothing like this, I hasten to add, but it was introduced in around 1986 or so, and in the late 90s we saw the very nice paper by Karam Khan identifying or reflecting that histopathology within the tendon when they went to surgery was actually fairly well typified by the grayscale ultrasound taken before. So this gave us then a non-invasive means of being able to look, if you like, or get some idea of what was going on inside the tendon at that time. Out of that, some very large ultrasound series through Jill Cook's PhD and others, and along the way they looked at other risk factors, and as you see here. There was also some pretty nice work also done with looking at volleyball teams in particular and the changes in their patellar tendons as they trained over a couple of seasons. And this is very well described by Giesslin, and there's some other work done by Peter Maliaris. And also there was a small paper which certainly changed my thinking and gave us some insight in perhaps picked up a little bit on what we might have heard or seen from that original Williams paper as well. So this is Karim Khan back in the 90s, so nowhere near as debonair as he looks today, but that was him in his youth when he used to look after the Australian women's basketball team. This is the material from Peter Maliaris' paper, and what this does really is look at, they looked at the tendons each month with ultrasound, and they looked at their baseline, which you see on the top row here, and then where they'd gone a month later in terms of the ultrasound appearance of the tendons. And at baseline, they were divided up, this cohort, and trichotomized, if you like, into normal, reactive and degenerative, if whether or not you like these terms, in terms of appearance. And then looking them at the end of the month, you can see that there was quite some change, particularly in these ones with diffuse thickening or early reactive tendinopathy, where some could reverse and some could actually progress. And so this concept that it's a fairly quiescent sort of thing is perhaps not the best reflection, and perhaps we should think more in our patients and others that we can get quite dynamic changes within the matrix at times, certainly to ultrasound. We then should question far more than perhaps what this means in terms of the tissue science behind it. So this was Jill's paper, and I've just put it up here, where it was only 18 tendons, and these were tendons that were harvested as before undergoing bone-tendon bone graft for ACL. And they looked then, and they were asymptomatic, but they looked for changes in those tendons within their histology. And they found a sort of sequential array, if you like, so that they found tendons with only changes to the tenocytes. In terms of rounding up of the tenocytes, they found tendons with changes to the tenocytes and changes to the ground substance, and they also had a larger group with the first two plus collagenous or matrix breakdown. And I need to put this also more in the context of more contemporary thinking later, but this was a means perhaps of perhaps understanding a sequential array of events, notwithstanding this was a cross-sectional study. But the main thing here is that collagenous or these frankly, and these were quite large changes in the collagenous matrix, were not seen without the other two elements prior to that, either cell changes or ground substance changes. So that perhaps gave some insight there, but I know that can be challenged, and perhaps when we look at the more contemporary work of Shepherd and Pingle in Michael's group and others, that I think there's a tighter relationship we need to explore. And here's Jill back in her younger days too. So we then come to the 90s and noughties up to now, and there's an enormous amount of work in some really key research units around the world, and they really have given us an enormous step forward in our understanding of a number of these different processes. So if we looked at cell communication systems, a large part of that work certainly earlier was done more as the colleagues of Hock and Alfredson up in in Sweden, across the bridge, but then also some excellent work also in the UK. Mike Benjamin and his colleagues work there, and also Magnus and Ingvar and others. So a lot of really good work. I mean, essentially looking at the cell communication system where, of course, there are gap junctions, but there's also an autocrine-paracrine system. There is this very powerful sort of mechanotransduction where the cells are intimately related with the collagenous matrix and are able to reflect and react to changes within that matrix. If we look further at the matrix structure, and in great humility, I would love to really give huge credit to Michael Carr and his colleagues for the enormous amount of work, and certainly the amount that it's increased my own understanding of very, very complex mechanisms, and also just the strategic manner in which these issues have been explored, and I think have really added an enormous amount to our overall understanding. Others in this area, of course, David Hart, George Morell's done some work, or done a little more work, and in understanding a little more of the protoglycan pathways, Chris Handley in particular in Melbourne, and others as well, and which I'll go into more depth later. Also, again, in the Copenhagen group, they're really good insights into tendon responses to load, and I think it really underpins, in a way, our understanding of perhaps how we might be able to load tendons at the moment, but of course there's so much more to learn. And in fact, the earlier work with first author of Henning Langeberg and others, I think, gave us this very tiny graph I've put up here, but looking at 1, 2 and 3 day responses to exhaustive treadmill running, showing that it's about 3 days after intensive overuse that the tendon cell response and tendon collagenous response, or pro-collagen response, peaks. So perhaps certainly we took this as clinicians that this might add insight into it's really only every second or third day that we should be able to load these tendons to really high levels. And that, as you know, has formed the basis of what is being adopted clinically, and in fact what the horse trainers and others have done empirically for many years too. So, but there's so much more to learn here, and you see the latter authors are continuing on in this work, but I think this early work in the late 90s and 2000 really has guided us a lot. There's other things within the latter part of the last century, is that originally there was some thinking that females were more at risk of tendinopathy, but more lately it's been determined that that oestrogen in particular seems rather protective of the tendon matrix, and it's more post-menopause that we start to see women with more issues. There was, of course, the roller coaster ride of discovering vascularity and associating that with pain, but then subsequently learning that in fact this wasn't a strong association and has now pretty much been ditched. And then the ongoing debates around, is it inflammation or not? And you know, Clancy started the ball rolling, and then of course Purdam said no, it's definitely not inflammatory. David Hart's been a big proponent of the involvement of the mast cell and some pro-inflammatory processes, and Smith and Webborn and Miller have picked up on this too, and I'll revisit this in a little while as well. So where do we think we are at present? So there's a tissue science model, and where we consider an enormous number of elements that contribute to tendon matrix function. Obviously the collagens, the tendon cells, and the proteoglycans. And the tendon cells and their communication, as I mentioned earlier, you know, obviously the driver of maintenance of the matrix, but also the glycoproteins, matrix mediators, the cytokines and growth factors, mechanotransduction elements, and neuropeptides. So, you know, there are all these elements that are being considered by all the tissue scientists, and And this is very much the simplified model too. To see their diagrams takes us to another world. But again, great credit to them. To understand tendinopathy and understand anything, we like to know something of a natural history, but we don't have an awful lot in terms of natural history of tendinopathy. That is, tendons that are left to their own devices and then what happens to them. There's a little out there. The incidence of Achilles in the Dutch population was, as I recall, 1.85 per thousand, so not all that high, but of course it has reasonable morbidity. There was the Kerhala study of Finnish athletes who were subjected to high loading in their prime years, and very large series, and if you're a middle distance runner or long distance runner, you had a pretty high odds ratio of developing Achilles tendinopathy later in life. If you're a sprinter, you had a very high odds ratio of actually tendon rupture. There's probably some confounding elements here when we look back at track and field in the 80s, Tony, but I'll leave that to your own means as how you might want to interpret that. Karen Silbernagel did a nice study looking at the natural history, I guess, of 34 people over 5 years with Achilles tendinopathy, and although there were about 25% of them recurred during the period, that there was about an 80% resolution. But I think this is something we could try and learn a little more of, is the untouched tendinopathies or managed, is to see actually what happens to them. If we look at tendon adaptation to load, and here I'm looking more in a whole of tendon sense, and we'll look a little more later at some of the other tissue science aspects too, I think. But if we look at loading up an Achilles tendon with eccentric exercise, that Nicole Grigg and others showed that acutely after the exercise we had a reduction in bound water within the tendon, and over 24 hours it would pretty much resume its normal dimension. And if we had tendinopathy, there was actually less of this effect. That is, there was less loss of water because, again, a higher aggrecan population, it binds water more powerfully, and so there's less ability for this fluid flow in and out of tendons. If we look at some studies done on acute loads of 1 to 4 days, and again we can come back to Henning and Langeberg and other paper here, that we see this increase in tissue response at 2 to 4 days after exhaustive exercise. Using the UTC, ultrasound tissue characterisation, they've been able to show that while there are subtle ground substance changes early, that these are pretty much resolved, or what we think are ground substance changes, but certainly a slight disruption or loosening of the matrix, if I may use that term, appears to resolve within 4 days or so. There's some nice work, and again, Mads Kongsgaard, who came and spent some time with us very early, and his really nice work on if we undertake a heavy resistance program, that we can actually change the morphology of the tendon, changing both very much the collagenous matrix and attendant elements, and so that they could actually change the cross-sectional area of the tendon. And also studies around habitual heavy users of patella tendons, so badminton players, also had higher cross-sectional areas. Also, a very recent study, Sean Docking, looking back at their UTC pictures of pathological tendons. And just to acquaint you here that this is a normal patella tendon. So the matrix is generally represented as green and blue in terms of colour coding. Pathological tendon is pretty much seen as red or black, and in this moderately pathological tendon, we've got an area of effectively degeneration within the tendon there. But the interesting thing that he's found is that when he went back and looked over quite a large series, is that the cross-sectional area of this tendon is not as great as the cross-sectional area of the green and blue that is normally load-bearing collagen within this particular tendon too. So it appears, although we still need longitudinal data, this is only cross-sectional at the moment, that there is a naturally occurring substance which makes sense from mechanotransduction where the tendon can respond to the increase in load due to the deficit of this non-load-bearing area here, and effectively adapt to that. So this really changes our thinking, but there's a lot more ahead yet in this area. There's been, you've seen a number of tendinopathy models, and this is going to be a very crude attempt at trying to summarise them, but essentially recognising perhaps the 7 or so tendinopathy models out there to date. But as a matter of, there's no doubt there's more work to be done in this area. So Ledbetter had this concept where, and it was really about normal tissue adaptation. Once we overloaded the tendon, it got to a maladaptive state, which was either reversible or we went into this cell death and tendinosis sort of cycle. Anofsky, and I went back and read this just the other day, his I think stands up very well even in contemporary, some of the contemporary findings, where he questioned whether the tendon cells were responding in terms of rounding up according to being overloaded, or in fact was it being underloaded? That is, as they were being decoupled from the matrix, that then they were seeing no loads, so they responded in a certain manner. Our own model with Jill was very much looking at, the understanding of pathology at that time, and really trying to provide some sort of clinical meaning to that, to be able to both ask clinicians to not treat all tendons the same, that earlier tendons need to be managed in a slightly different way to later tendons, and really to try and provide some sort of clinical meaning to a lot of these papers. Michelle Abate, she introduced this concept within the pathogenesis of whether or not there coexists both inflammation and degeneration, and pretty much ends up with that as her punchline. And I think, again, this is something that holds up in the present day. Coombe and Bill Fincenzino, and many of you would know Bill. I don't know whether he's been here or not, but so they came up with their ongoing studies in pain of pulling together a pathology model, a pain model, but also introduced this concept that there are actually motor system changes associated with tendinopathy, something that is now borne up more and more. So in fact, they introduced this concept back in 2009. Fu introduced, again, a failed healing sort of model with multiple inputs. It could be laceration, it could be chemical irritation, it could be other forms of input, leading to this injury, failed healing, and hence clinical presentation. And Chris Littlewood presented to you yesterday, so I think he did a far better job than I, but essentially he spoke then of long-term tendon conditioning being subjected to an overuse event, that we then get, as part of all this ongoing CNS scrutiny of what's going on in this particular part of our body, and out of that, an output of tendon pain, which is modulated, of course, by the both positive and negative responses, and a term which I've forgotten was associated with it too. So then comes an ability of, or a very poor ability of trying to group these, if you like. So this is, again, very crude. But if we took those with that had a cell matrix to tissue adaptation sort of approach with reversibility in the early stages, it would be these models. If we took it ones that were primarily about matrix breakdown, it might be Arnofsky and Abate, particularly early. Ones that looked at inflammatory markers coexisting with cell tissue degeneration, again, these. And then lastly, but very importantly, those of the looking at tendon pain as such. And so I think when we sit back and look at all this, yeah, we've got some great models, but I think there's still a need really to pull all of these together into mega model or a meta model or whatever, because I think, in fairness, no one's really cracked what this should look like as yet. So any of you who are keen, off you go. Andy presented very nicely on tissue, or is there inflammation, and Per Hölmich has dropped me in it again, asking me also to talk on is there tissue inflammation, and thankfully I took on a slightly different approach of talking more about the cytokines rather than the cells. So hopefully these should complement each other, but again I invite more input from the experts, the real experts in the room. So we've got, and Rees and Scott actually, so John Rees is a rheumatologist in the UK, and he and Alex Scott actually really advanced, well, you know, maybe there is inflammation and there's evidence of all these signalling, pro-inflammatory signalling elements within the, identified within tendinopathy. But a year later, there was again the beautiful work from Michael Chia's group, where looking at where these in fact are involved. So in the normal tendon, the COX-2, PGE2 and IL-6 in particular very much appear to take a signalling as part of the normal adaptation of the outer portion of the tendon to mechanical loading. And we can block this, or they can block it quite effectively with anti-inflammatories. So, but then also the co-worker Jessica Pingle looked at or authored the paper on chronic tendinopathy, and they took tissue samples from both the painful and non-painful portions of the tendon and demonstrated that primary cytokine involvement there in fact was not the former, but more of VEGF, transforming growth factor beta, and also IGF-1, that the more inflammatory, or more commonly recognised inflammatory mediators were pretty much down-regulated or unchanged after acute loading, whereas the former ones were upregulated. So it tends to suggest that certainly in chronic tendinopathy there is no real pro-inflammatory sort of response, would be perhaps my messaging back to you, but again I invite more expert opinion. Often also has been raised, you know, is it a matter of degrees? So we see, it's been reported by Legalots that there was IL-6 was increased, say 28-fold in loading with, or in tendinopathy, but there's a 180-fold increase of IL-6 when we looked at tendon rupture, so significantly more. And then if we look at infection, we see higher rates again. So maybe we should be considering it more that, yes, these things are involved, but it's not the true inflammatory cascade as such, or certainly from a cytokine perspective. Ben Dean article, really that's part of the work that Andy produced to you yesterday, so I think I won't do that anywhere near the justice that he did. And just two last elements in looking at this is this concept of the link of tendinopathy with obesity. And there are two elements here, or three elements really. The first one was, do more obese people actually load their tendons more? And there's something of that, it appears, certainly from Alex Scott's most recent article, but also the dyslipidemia that's associated with it ends up with actually inducing a dysfunction in the tendon cells, so they're not able to maintain the matrix in the same manner. So that that's the second element within obesity link. And the third element really is the association that Michelle Abate also talks about, where our adipokines, that is the cytokines produced by the fat cells in our abdomen, are or produce this this low-grade systemic inflammation, and so that is going on within these people as well. Okay, I'll come a bit more to my own comfort zone, I think. So, looking at pain and motor changes within tendinopathy, and if we look at the research, that tendons are really hyponeural, whichever way you challenge Patrick Danielson's and others of the world. But in fact, there is quite profound signalling within the tendons, again, by this autocrine-paracrine process. Acetylcholine, glutamate, substance P, TNF, NPY. And also the Schitz's paper, which told us that this increase in glutamate and NMDA receptors co-localise within the tendon itself, as well as, of course, the latter changes in the spinal cord, which is discussed later. So this certainly is an element, and I think, like you, Andy, I'm very keen to learn more of glutamate and its association within these pain responses. Other pathways proposed at a local level here, ion channels. So we've got stretch-activated, voltage-gated, and ion-gated and ion channels. So, and they all correlate. So, of course, they can be mechanoreceptive, and that might give us some idea of, how do we get this immediate pain that then disappears very soon after loading. Other elements are, increased aggrecan in the matrix was correlated with pain by ATA in 2014. There are spinal changes, which you would know, that inducing a tendinopathy on this side of a rabbit, resting this side, but induces the same pathological changes in the tendons on the opposite side. So this was demonstrated by Backman and others. Similarly, in humans, people with a unilateral tendinopathy actually have bilateral sensory changes, and again, this has been well described. I think you'd all know this very well. In terms of spinal modulation, in Van Wilgen's pilot study, he actually commented, and we've had some of our own data, in athletes that they may downregulate the pain in their tendinopathy, but more commonly we hear of upregulation of pain responses in as part of spinal modulation. And lastly, of course, the work of Ebony Rio, which was introduced yesterday too, which was at a spinal level. She found on FMS testing that there was an increase in corticospinal or motor excitability. The others we were talking here was sensory. In terms of cortical level, I don't have an awful lot in terms of to share with you at the moment in terms of lower limb tendinopathy, but this could be that I've just not been complete in my search, and I apologise for that. But what we do know is there is this motor cortex inhibition. So in fact, this is what drives the overall motor inhibition that we'll see in the upcoming slides that is associated with tendinopathy. But we do know that these motor changes are partially reversed when we do loaded isometrics. So this is a means of being able to actually change or modulate this particular phenomenon at the moment. Another area I'm less comfortable, but we'll talk about it. So if we look at central sensitisation, there's a couple of meta-analyses just completed. The first one, Melanie Klinziger, and they looked at across 16 studies, and of which 14 were upper limb, and there's really not a lot of lower limb data within here, and they found changes in pressure point thresholds and hyperalgesia and other changes, with small groups actually having cold pressor changes as well. And so they actually suggest that there is a good association between persistent tendinopathy and sensitisation of the nervous system, but were unable, or they were not confident in extrapolating this to lower limb tendinopathies. Sanchez, who I'm sure Andy knows quite well, they looked at a meta-analysis of 10 shoulder papers with a view to central sensitisation, and Joe Neese was a co-author on this, and who's led some other work as well. And they're really looking at whether we can essentially call it or typify it as central sensitisation or not. And they were fairly, I thought, coy in their conclusions. And if I just read this to you, so that they acknowledged that there are peripheral mechanisms of generating pain. They acknowledged a hypersensitivity of the central nervous system in a subgroup within the shoulder pain population, and they're talking here of unilateral shoulder rotator cuff tendinopathies, and certainly not any hemiplegic shoulders as well. But they went on to say that understanding the role of central sensitisation is still in its infancy, and they weren't really keen on saying, yes, this is central sensitisation. But I think there's a reason for that we'll see just after this next event here. Andy presented this yesterday. I was unable to find the Tendon paper, and he's been most generous in assisting me. But this fabulous paper where they looked at hip arthroplasty, and so they looked at the thalamic changes in the brain prior to surgery, and they showed thalamic atrophy, undergo painful hip, of course it was painful prior to arthroplasty, and it's a fact in following them up post-arthroplasty, where their local pain generation, if you like, had been significantly reduced, that they then saw a normalisation or close to normalisation of the thalamus. So this is really exciting as a method. Now, what we are interested in is whether this happens in tendinopathy or not, and Andy has it, and we're all very keen to get down and read that a little more. I think this is, this bringing in from other areas to understand tendinopathy more is, I think, our only way, or one of the very fruitful ways forward. All right, so Joe Neese was on this central sensitisation paper, and they've proposed a new method of looking at central sensitisation, almost trying to tighten up what we can call central sensitisation or not. Here they wanted to exclude initially neuropathic pain, okay, which actually changes our approaches or our ability to use certain instruments and other things as well. And then they wanted to differentiate between nociceptive pain and central sensitisation. Nociceptive pain is still sort of included in there where you have pain disproportionate to injury or pathology. So that might include a number of the tendinopathies that we see that are really ongoing and recalcitrant, and perhaps have other features of hyperalgesia as well. But they also go on to where you're trying to typify, I guess, central sensitisation pain. This is where we get hypersensitivity of other senses, so abilities or sensitisation to noise, to certain foods, to photophobia, etc. So it's looking at a multi-system sort of approach. So this is really outside the typical patients that we see. So just be aware of this. I think it's something to just sort of sit back and allow them to do their thing first, and we can look at where we might fit in the greater picture later. If we look at tendinopathy and performance, we do know that tendinopathy is associated with better jumping ability. They land from a higher height, and altered landing biomechanics. They tend to land a little more stiffly in a different manner. If we look at the total leg, in this case lower limb, changes, that there are decreases in muscle, tendon and leg stiffness. So generally it's a more compliant leg. People are actually less strong, so they're unable to resist these landing forces. There's a decrease in proprioception, decrease in reaction time. These are more upper limb things. But this is a key element, if I can just bring you back here, is that a number of papers now, as well as describing bilateral sensory changes, there are bilateral motor changes. So in the hip, we've got bilateral weakness of gluteus medius. In the upper limb, bilateral weakness of our extensor carpi radialis brevis. Bilateral weakness in the calves with Seth O'Neill's work. So that this is something, again, we need to consider in looking at these patients, of how we might need to better manage them in toto as a patient. And lastly, and again, a very interesting concept here introduced by Ebony, where there's a change in motor modulation. So normally we put an input in, and our brain is able to control how much tension. As we put more input in, we get greater tension in the muscle. So it allows us then to modulate our landing or whatever according to how much actual tension we need at a particular time. Whereas the change on fMRI was, or FMS, I beg your pardon, was that we could provide input, stimulus here on this line, and then all of a sudden it would contract maximally, and then we really lost our modulation. And I think we see this clinically too, so that rather than there's people landing and modulating their force according to requirements, they tend to land very stiffly, and that we've got other sort of snatch and grab sort of responses in the different muscle tendon units as well. So I think learning this more, knowing that it is partially reversible with ongoing training and perhaps a lot of the strength work that we undertake is something that we should consider more. What we don't know is whether they precede or are as a result of the pain. There's some great work being done on genetics by Malcolm Collins' group. And initially they looked at pretty much univariate sort of approaches. Did this particular gene or this particular gene actually, what were their associations with tendinopathy? But more recently they've done some very complex multifactorial studies where they looked at combinations of 3 genes out of type 27 collagen, type 5 collagen, and the caspase 8 pathway. And this actually gave the strongest relationship yet, although it needs to be said that they also included sex within this, or gender, and it by far was the strongest of the univariate statistics or contributors to this. There's no work done in a lot of other elements yet, though, within the matrix. So looking to the future, what will be like? What will be like? We'd love to see clinical studies of early tendinopathy. We just don't have them. So much of this is this late stage at the moment. The only one out there is Nellie Mayhew. I would really, and I think many would share, just understanding more the local and central nervous system pain changes. And we're getting more insights, and even in the last 5 years, I think come a long way. And also, is there something about the at-risk individuals that we can understand a little better? We can't expect that everyone gets the same response to particular medications, and this whole area of pharmacogenomics is blossoming as we speak. But if we had our way, could we get things that actually modulate the cell activation or communication, or this sensitization, again, that Andy mentioned yesterday in the early stages? That would really be something, but we don't want a downside. So, this is looking to really sophisticated things rather than the blunt instruments of the anti-inflammatories and other things that are used at the moment. Also, perhaps being able to change pain in this particular sensitised group. And lastly, and of great interest to me, and also Rod Whiteley sitting up here in front, is that of exploring optimisation of loading. Do we have markers other than pain for getting our loading right, or is it really just about modelling? And we don't know that yet. But looking at a very good paper by, I'll lead into this first. The work that we've done and many others have done actually have tracked athletes over time. So if we look at the 4-week training load and average that's our chronic load. How much load our whole body sees, but then our cell matrix sees as well. Okay, and on top of that, we then look at the load in the last week. So if we drop our load, of course, that subsequently we see this drop in chronic load. If we spike our load, then we see a difference to the loading history for the tissue before it. And we know that if we spike our load more than about 50 to 60%, that's pretty much the point at which we see onset of tendon pain within the 2,000 or 3,000 athletes that are being tracked in the database in Australia at the moment. There's a couple of really good papers, John Orchard and also Tim Gabbett, and Rob was on this paper, where rather than looking just at load spikes, we also need to consider periods of relative rest, where in fact you've not stimulated the matrix in the way that it would like to see, and then all of a sudden loaded as you would normally, but that's too much for what the matrix is able to cope with at the moment. So that underuse and overuse are quite relevant here. That if we look at the data in cricket, that moderate to high training loads maintained over this period is quite protective for for tendinopathy. That is, you're 3 times less likely to get a tendinopathy if you've carried quite high loads. And also over career, even 4 times more protected than normal. Whereas if we put on these very high acute loads, you're at much greater risk of injuries, 3 to 4 times. So what does this look like? This is not a tendinopathy, but this is pretty much how they would present. So we're tickling along at a particular load like this. So this is looking at our daily load in this particular athlete. And of course, they've clearly overloaded here. This is their chronic load responses in black, the acute load responses in red. There's clearly greater than 50% rise here, and this is where they succumb to injury. They then needed to rest for a while, and then, of course, got their loading back up, but again went through a period of heavy loading and succumbed again. We call this the boom-bust cycle, and I guess you know this very well in the athletes that you see. But over time, if you really work through with these athletes, you can get to nirvana here, where if we can maintain very high, and these are higher loads than what we were succumbing to earlier, by this graduated adaptation of our whole body to these loads. And this is really, I think, one of the ways of the future, and pretty exciting for us as well. New technologies, we can look at UTC, microbubbles, MRIs, and these gives us different ways of looking inside tendons. We'd love to understand the onset of the pathology better. The tipping point between adaptation and then tipping off into tendinopathy. What changes there, and can we really get this? Some of the really small system modelling by Screen, and also I think used in Jessica Pingle's study, actually looks at fairly small preparations where they're able to show the interrelationship between collagen and this little buckling occurring between tenocytes and collagen at the very early stages. And again, and this was before you spoke yesterday, Andy, but this mechanism of apparent sensitisation of the tenocytes, which clinically has been quite apparent to us, but this concept of the stromal cells that you mentioned yesterday, I think, is of great interest to us. Understanding more of what's variable within the pathways. Is this all immutable, so that once this happens, then this happens, then this happens, or is there genetic variability between all of us in how we undertake some of these processes? Understanding tender paths and resilience, understanding how we might reverse things, and can we prevent this perpetuation and bilaterality through doing something in the dorsal horn of the spine? Sensory motor changes. Is there a Higgs boson for us out there? Is there something that really, something we haven't discovered yet, which is a way in which the tendon's using to sort of sense what's going on? And again, I really like Chris Littlewood's point of this surveying or sensing, what's going on in this tissue. Our brain wants to know. And I think this is some of the reason, is pain necessarily bad? I think sometimes it is just a monitoring of what's going on there. Apparent differences between upper and lower limb, differences in kinetic chain. We should ask ourselves though, can we or should we block pain? They tried this years ago in AFL football where it's only pain, so we'll put some local anaesthetic and go out and play. And we had some shocking, that only lasted a couple of weeks, I think, and then a couple of years for these guys to get over it. So that clearly that's not the way. I think we've got to be more clever and look more holistically at that. So is pain pathological or is it actually physiological? Is it about telling us, no, we shouldn't load this until we're ready to? That said though, not too many tendinopathies do go on and rupture. So let's keep this in mind with how we might consider these things. Preventing tendinopathy, there's not much out there at the moment, but what might we think of? We haven't really looked at the loading history of in their development years as they have in bone, and I think this is something that we could learn more from too. Again, picking up from Henning's work of timing of load adaptation cycles. So we know out to 3 days. What happens to 7 or 8 days? What happens when we actually subject a matrix to cyclical loading? It'd be great to know these things, but again, appreciate the real challenges in doing this at a tissue science level. We do know that variability of a technique does have a place to play. So again, if I jump multiple times, it'll subtly change how I accept my load to in fact spare my tendons and spare my muscles and change things around. But in fact, it appears that people with tendinopathy get really quite unimodal in the way that they're loading their tissues, and perhaps this is part of it, that we need to get back to looking at motor variability. Landing strategies, kinetic chain factors have all been mentioned before, but we do know that in optimising landing, not adding extra load or extra exercise load through training. We know little of nutritional supplements and other things, but there is a little work being done out there, again in Copenhagen Group and others, which we watch with great interest. So if we sit back and mark ourselves, we probably do, to Robert Curlin 40 years ago now. Inflammatory and degenerative responses, yes, we probably understand this much better, and probably more so in the last 3 or 4 years. Nomenclatures, yep, we've probably got ourselves there, but this, why some develop and not others, we don't know that as well, but certainly things such as loading history, I think is a very real element here, and prevention is something we could do more work in. So final thoughts, it's multi-system, multifaceted, and we really can't expect a magic bullet. There are some fundamentals. It's going to come down to exercise and loading. There is no way around that. But also unloading the way we subject our tendons to load through modifying training load, kinetic chain, motor variability. Intervening appropriate to the stage, and looking also at sensory motor adaptations too. If we had a magic intervention, what would it be? It might be these things, but that's going to be a real challenge to us. So I think I'd like to close there, and thank you very much.